Good morning. So I guess Dr. Rose had a scheduling conflict, so Raf told me to talk about stroke in the second part. We're going to talk about pulmonary embolism first. And the reason we're doing this is because a lot of hospitals can do this new thing called ECOS. Anybody heard of what ECOS is? Well, good. Hopefully you'll learn something about it. So normally, scenario one, you have a 30-year-old female, complains of chest pain, shortness of breath, left arm pain for about 3 hours, past medical history, anxiety, meds, birth control pills, she's on Xanax, physical exam is normal, heart rate as you see is 102, respiratory rate's 24, SAT is 98, blood pressure is 100/60. First of all, anybody recognize that lady? Toni Braxton, right? Because she had a PE. So what do you do with this patient? What protocol do you follow with that patient? Right? What'd you do? Just chest pain, anxiety, behavioral health? Scenario two, 63-year-old female, history of CLL. What's CLL? You guys can talk, you know, it's really loud. So, chest pain, shortness of breath, left arm pain and swelling for 30 minutes. Physical exam normal, except she's got wheezing and she's got left arm pain to palpation. Past medical history, hypertension, she's diabetic, lung cancer, COPD. She's on Norvasc, Glucophage, Combivent, and those are her vitals. Heart rate's 80, respiratory rate's 22, SAT's 91, blood pressure's 95/55. So what do you do with this patient? What do you just transport as chest pain? Right? That's probably what most people would do, same as the first one. So what's a PE? Well, pulmonary embolism is a clot, as you see in that picture. It's a sudden blockage of one of the arteries in the lungs, and it occurs 600,000 cases a year. And 80% occur without any prior symptoms at all. And sudden death is the first symptom in 25% of these people. Now, that should be significant because what protocol would that be under? Cardiac arrest, right? So when you're doing cardiac arrest and you look at the PEA diagnosis, you got the H's and T's, and one of them is? Pulmonary embolism. So 200,000 deaths a year, so think of it, a third of the people who have a PE die. It's the number 3 cause of death in hospitalist patients, and the mortality rate, as you said, a third of the people who have it will die. The 1-year mortality rate, if you have a PE, is 24%, and 2/3 of the deaths of these people occur within 30 minutes of the embolization. So if you don't get it quick, they're going to die, and if you get it, there's a high probability that will die. Now, PE basically presents with chest pain, right? So why do we miss so many of them? What are we doing? You know, the problem is also with pulmonary embolism, the mortality rate's higher than basically traumas, breast cancer, and HIV combined. So if you look at that in a graph, obviously heart attack, MI is the #1 killer, but then you also have PE, and then if you add HIV, breast cancer, and motor vehicle accidents combined, it's significantly less than just pulmonary embolism. So what's your classic signs? You have sudden shortness of breath, pleuritic chest pain, hypoxia, which means your oxygen saturation is low, and they have coughing symptoms. So the problem with it is really the diagnosis is nonspecific. And what happens is on autopsy that they found these people with pulmonary embolism, less than 30% had signs and symptoms of anything specific. And the scary thing is this. The people who actually end up having a pulmonary embolism, 40% of them actually went to their physician the week or two before they had these symptoms. So, again, nonspecific, you really can't tell what's going on, but they will suddenly collapse if you're not listening to what they're telling you. Now, this could be your doctor, I don't know, and you've probably run on many people who have this person as their doctor, but you want to be aware of these symptoms so you can help people like this. So what are your risk factors for basically pulmonary embolism? The big things are previous history of blood clots on your legs, immobilization, surgery, cancer, if you've been traveling more than 4 hours specifically, if you've got thrombophlebitis, congestive heart failure, any autoimmune disease, smoking, and birth control pills. Now, it's more essentially to be aware of women. Why do we are more aware about women, because women are far more stubborn than men are. And this is because they will not go in until everything else is fine. So they worry about everybody else, and they're the last people to actually go in and get treated. So in women, high risk factors for pulmonary embolism are obesity, pregnancy, heavy smoking, more than 25 cigarettes a day, and hypertension. And remember, women are tougher than we are, because when they get sick, the whole family goes to pot. So how or what kind of questions do you ask somebody who might or have a pulmonary embolism?
Yeah, I'm married. Doesn't matter. You do that for me? Really? Yeah, I'd like that.
Who are you talking to?
It's Jake from State Farm. Sounds like a really good deal.
Jake from State Farm at 3 in the morning? Who is this?
It's Jake from State Farm.
What are you wearing, Jake from State Farm?
Khakis.
She sounds hideous.
Well, she's a guy, so.
And our Jake from State Farm's based in the second row and is wearing khakis. So if you look at pulmonary embolism, what are the signs and symptoms you're looking for people with this disorder? So they did a study over 4 years, and they studied VQ scans, which tells you the difference between perfusion and ventilation in the lungs. So what do you think are the top 3 symptoms of pulmonary embolism? What about the number 1 sign of pulmonary embolism? So, number 1 symptom is shortness of breath. Number 1 sign is basically tachypnea. Number 2, pleuritic pain and rales. And number 3, you have anterior chest pain and tachycardia. Now in children, we always have to be aware of that because they're present always a little different than we do. But they basically are hemodynamically stable, and they handle changes better, but basically 50% of them will have signs of tachycardia and cough, and hemoptysis, which is coughing up blood. And 98% of people who have children who have pulmonary embolism have some form of underlying genetic disorder. So this is a little caveat study that just came out in the last year, and they kind of correlated syncope with pulmonary embolism. So they basically studied patients over a 2-year period, and they found that 17% of people who basically passed out had pulmonary embolism too. And they could find a quarter of the people who passed out had symptoms of pulmonary embolism too that they couldn't find what the cause is. The reason is when you have a syncopal event that you pass out, it's basically you have an obstruction of your pulmonary arteries, which causes vasoconstriction around the perfusing organs, and as a result, that causes collapse. So just be aware if somebody has a presentation of syncope, could this potentially be a pulmonary embolism too with risk factors? So what are the different types of pulmonary embolism you have? There's acute or chronic. Basically, if they have, you look at the lungs and you look at a cross-sectional area. If it's acute, the clot is basically in the middle of the lung, and if it's a chronic one, it's in the periphery of the lung, so the vessels. So as a result, this is similar to STEMIs and non-STEMIs. So you know basically when you have a STEMI, it's a central occlusion. When it's a non-STEMI, it's a peripheral occlusion. And also when you look at it too, another diagnostic tool of looking at the chronic and acute is just the different pathologies that you look for when you see them. A non-massive pulmonary embolism is something basically you have a pulmonary embolism, but the patient is doing basically stable, there's no issues going on, mortality rate is less than 5% in the next 3 months. The one we are concerned about is the massive pulmonary embolism. Basically, this is when you have unstable vital signs. Your systolic blood pressure is less than 90, your MAP's less than 65, you're tachycardic, you've altered mental status, and you have oliguria. It's the number 2 cause of death, and basically the mortality rate is between 30 to 60% if you have a massive pulmonary embolism. So what does a massive pulmonary embolism look like? This is called a saddle emboli, and it blocks both your arteries going through, and as a result, blood flow diminishes. That's why your mortality rate is so high. So what are the side effects of having a pulmonary embolism? So basically you have a blood clot which kills a part of your lung, so that's a pulmonary infarction. There's a loss of local surfactant. This causes increased dead space because there's no perfusion behind that part of the lung. You have hyperventilation, so the body tries to compensate for the lack of oxygen because it's not working. And you get hypoxia, which is a ventilation and perfusion mismatch of flow and oxygenation. And these are basically the signs and symptoms that a patient will present with when they have pulmonary embolism. This is what a big clot looks like that they can pull out. Now, what are your risk factors? You've got basically your hereditary risk factors of being hypercoagulable. It means your blood's thicker than normal. And 7% of the population have blood thicker than normal people. And your risk factors are protein C, protein S, antithrombin 3. The number one clotting problem is called factor V Leiden deficiency. And what these people do have a high propensity to have really thick blood. They clot more than others, and as a result, they have these blood clots and they have pulmonary embolisms. So what are your top 3 acquired risk factors of having a pulmonary embolism? What's your number 1? All right, number 3 is trauma, and that's from major surgery. Number 2, malignancy, and that's breast cancer. Number 1 is pregnancy, and you have birth control pills too. So anybody who have any of these risk factors, think pulmonary embolism, think DVTs. If you don't treat them, this is what's going to happen to them. Everything swells up, they do a fasciotomy, cut open the leg, and then drain the tissue. So let's go basically in reverse order. The number 3 cause is surgery. And we send a lot of trauma alerts to everybody. When we send the trauma alerts, a lot of them have DVTs. 58% occur in the lower extremities, primarily if you have injuries to your tibia and femur fractures. And pulmonary embolism occurs in 15% of these long bone fractures. Number 2, cancer. What happens is 17% of people have this malignancy, which causes thicker blood, increases your chance of having called venous thromboembolism. So what are the top 3 cancers that will cause you to have PEs or DVTs? What's number 3? Colon cancer, stomach cancer, and we already talked about number 1 is? Breast cancer, right? So when it comes to pregnancy, that's your number 1 cause. And this basically have DVTs, and if they have them, they'll have them in the left leg 80% of the time. And when you look at them, they'll primarily occur between the weeks of 25 to 29 weeks, and they will also last up to 6 weeks post-delivery too. When you're pregnant, your blood's thicker, so all the joys of pregnancy, weight gain, water retention, lack of sleep. If men were pregnant, there'd be no overpopulation, just so you know. So basically your clotting factors go up, fibrin generation is increased, that's why you have clots. And this is how we celebrate the joy of pregnancy that you guys have. Now, we talk about oral contraceptives as being a big risk factor for having DVTs and pulmonary embolism. And it's really related to the amount of estrogen content you have in your birth control pills. And the problem is, the higher the concentration of estrogen, the higher the risk factors of having clots. So, to have a pulmonary embolism, you need to have a clot travel from some place to another to get to the lungs. Risk factors, we talked about immobilization for like 4 hours, history of DVTs. So what is the DVT? DVT basically is a clot that occurs and develops in the lower legs, venous system of your legs, and the problems occur because when these clots break off from the veins and they go directly into your lungs. And the problem is the long-term risk of this is significantly higher if you don't get treated. So you'll see the clot basically fly off from the legs, travel up through the venous system, go through the heart into the lungs, and that's how you get a blood clot. And when you associate PEs and DVTs, 50% of people will have no signs and symptoms of anything. So 90% of pulmonary embolisms occur from DVTs in the following vessels: the iliac, femoral, popliteal, and tibial. 50% of these people who have DVTs have no symptoms whatsoever. So a lot of people will complain of like their calf hurting, pain behind their knee, but they basically shake it off as arthritis. So they figure, well, it's nothing really going on there, until you get an ultrasound and 50% of them have blood clots. Once they've developed this DVT, and if it becomes unstable, within 3 to 7 days, this clot can develop and form and flick off and go into your lungs. So it's really important to be really aware physically of what's going on. So we talked about risk factors for increasing your risk of DVTs. We talked about pulmonary embolism risk factors, your DVT risk factors, immobilization, more than 4 hours, cancer, smoking, COPD, heart failure, and pregnancy. So staying with pulmonary embolism and same with blood clots to your legs, how do you risk stratify to see how dangerous is this DVT and what's the chance of this causing a fatal outcome? So this thing called the Wells criteria that was developed. The Wells criteria was done to kind of classify somebody into the severities and risk factors of having a DVT and what's going to happen with them. So the Wells score is, if it's greater than 3, there's a 75% chance of having a DVT. If your Wells score is 1 to 2, you have a 17% of a DVT, and if it's less than 1, it's about 3% chance of having a blood clot. And these are the things, main risk factors you're looking for to see what would happen. And this is what the Wells assessment is. It gives you a numerical value based on what risk factors you have. So if you have cancer within the last 6 months, it's a 1. Entire leg swelling is a 1. So this is how you can classify the risk factors of somebody having a blood clot in your leg. Now, there's 2 simple clinical things that we can do. Homan sign, anybody heard of that? So what you do with the Homan sign? So you basically, you get pain behind the knee when you dorsiflex the foot, and it occurs 33% of the time, it's positive. And this is what you see, you get the leg extended, you push the foot towards the head, they've got pain behind the calf 33% of the time. This could be a sign of having a DVT. Anyone know what Virchow's triad is? So this is your risk factors for having a blood clot. So this is called venous stasis, you have hypercoagulability, and you have endothelial damage, usually from trauma. So trauma causes damaging of the integrity of your vascular system. And this is your triad to look at when you have a Virchow's triad, the risk factors you have. And if you break it down in general, this is your venous stasis risk factors, age over 40, which is really young as I get older, and heart failure, stroke, paralysis, and cancer, all these different risk factors you need to be able to assess and say, are these people risk factors for having blood clots, potentially having pulmonary embolism, and not just a simple chest pain. So the older people here, do they know who's in this picture? All right, who's the lady? And what did she have? She had a stroke. Gary Shandling, he used to sub in for Johnny Carson. Yeah, I'm old. So he basically had a pulmonary embolism. So what are your hemodynamics you're looking at? Basically, people will be normal and stable with a PE, and they can or have a DVT that will flick off, and they can be fine for 12 to 48 hours, but then suddenly, when it hits, within 48 hours, they can go to massive cor pulmonale. Anyone know what cor pulmonale is? All right, we'll cover that. This is your death spiral. And this is what you don't want to do and miss, and take the person to the wrong place and not have the ability to be aware of what you're looking for. And I'll cover each one of those in a little bit. So cor pulmonale basically is caused, it's basically right ventricular heart failure, a simpler way of doing it. You get pulmonary embolism, COPD, sleep apnea, lung scarring, high altitudes, and pulmonary fibrosis. And there's 2 types of cor pulmonale, which is right-sided heart failure. You've got chronic, which is right ventricular failure, and acute, which is basically acute cardiac dilation. So this is your normal heart, and this is what happens when you get a cor pulmonale. Remember, your right heart is much smaller than your left. So any increase in damage to your right heart is going to cause a lot of clinical complications much quicker than it would with the left. So what happens when you go into cor pulmonale? Your right ventricular wall stress increases. You have increased right ventricular pressure. When that pressure goes up, you have compression of your right coronary arteries. This causes your heart to have ischemic, so you basically in like a non-STEMI look. So they're having ischemia in the coronary arteries, decreases oxygen and blood flow. When the blood flow diminishes, you have decreased perfusion to your heart. When the blood flow decreases to your heart, you start getting microinfarctions, which are small, basically clots occurring in your ventricles. And this causes like an acute coronary syndrome. So clinically, when we check a troponin, they could be positive, but we're still not looking at the fact they could be having a pulmonary embolism, not a non-STEMI, so we're not being aggressive and doing the right thing and looking and classifying the difference between a pulmonary embolism and acute coronary syndrome. Now, what was the difference between this and acute coronary syndrome? If you both have chest pain and the troponins are coming back positive for both, what's the difference between the two? Between acute coronary syndrome and basically cor pulmonale. What's the one thing I've not mentioned that you would see a difference with? What do you do on every patient with chest pain? 12 lead, right? So you do a non-STEMI 12 lead, you're going to see what? Potentially ST depressions, ST changes. That's the difference between that and cor pulmonale. So you get right ventricular overload, failure develops, and then you also have elevated BNP, and we'll cover what that is a little bit. So this is your cor pulmonale, your right-sided heart failure, right ventricular becomes dilated, and eventually basically causes death from that. Your classic signs and symptoms of right-sided heart failure or cor pulmonale are basically shortness of breath, fatigue, increased heart rate, and lightheadedness. The treatment is basically you find the underlying cause. Is it a cardiac cause? Is it a pulmonary cause? Is it a parenchymal cause? Diuretics and also oxygen. This is obviously a massive blood clot, as you can see. We run tests called D-dimers in the hospital, and they are a great help and a great hindrance. The reason is basically it occurs and looks for basically any blood clots that occur in the body. The problem is it's very nonspecific. So if it's negative, that basically tells me there's no blood clot and there's no pulmonary embolism, and we can move on. However, every patient you want to get out quickly will have a equivocal D-dimer, so you have no idea what you have, so you've got to work up everything. Especially the ones you really want to go home will have just at that exact number where you're stuck and you have to do something. So if it's low, you're free. Unfortunately, whenever you want them to be free, they're never free. So what happens is the positive test means that you have a thrombosis, or you have to look up and see what's the cause of this positive value. So BNP is beta natriuretic peptide. That basically is a protein that occurs, or an enzyme that's released in the left atrium. As the pressure goes up, the left atrium expands. When it expands too much, it releases this called beta natriuretic protein peptide, and that is a result of increased volume. So things that cause your atrium to increase more is volume. As volume goes up, it causes more stretching. When stretching increases, it releases the BNP, and that's how you know there's volume overload with a patient. To diagnose these people, pulmonary angiography, and basically you put the dye into the lungs and you see the vascular flow and you see if there's any occlusions or blood clots around. So how do you look for EKG findings on somebody with a pulmonary embolism? We mentioned tachycardia as one of the signs and symptoms, tall and peak T waves, right axis deviation. Anyone know how to calculate right axis deviation? We'll cover that real quick. Right bundle branch block. This is the classic pattern, S1Q3 T3, if you ever see that. And it occurs about 10% of the time, but that's most probably a pulmonary embolism. And 20% of people have these kind of findings on EKG. So remember, right ventricular hypertrophy causes right axis deviation, a right bundle branch block. So think of all the rights, because you're having right-sided heart failure and cor pulmonale with a pulmonary embolism, right? So there's your EKG. It's your classic S1, Q3, T3 that you'll see on your EKG. That's your classic. Now, to calculate a right axis deviation, it's really, really, really simple. But it looks really, really, really complicated, right? So right axis deviation shows the electricity that's going through the heart. And their QRS, when you calculate that on your EKG, is going to be between 90 and 180. The QRS is positive in leads 3 in AVF, and QRS is negative in leads 1 in AVL. Who understands anything of what I said? Okay, there's 2 of you, but you're lying. Anyway, so this is the real way to calculate what your right axis deviation is. So if you look at the number here, and it's really, really hard, see what's circled? It says QRS, right? What's that number? It's circled in red. So it's what? So it has to be between 90 and 180. There's your right axis deviation. See how hard that was? So other things we can do. Before the days of technology, they had Westermarck signs, which basically was a focus of vasoconstriction in the distal part of your lung where this clot had occurred, and basically it's non-specific but it's sensitive. That's, if you look at that, you'll think of possibly what else could you think it would be. If you see that on chest x-ray, you're going to think it could be someone short of breath, chest pain, pneumonia, right? Hampton's hump is a wedge-shaped deformity in the periphery of the lungs. Again, these are very low sensitivity but very high specificity of what you get. And you have basically that wedge in the bottom right-hand side. That's your Hampton's hump. Again, these are very non-specific but very sensitive if you see it. The gold standard for us every day is CTA imaging. So basically we inject dye into the pulmonary arteries, and this tells us if you're having a blood clot or not. Angiography is still the gold standard, but this is what you'll see if it's positive. You'll see that decreased flow. See the areas that's really dark on that CT? That's where there's decreased flow or a thrombus. So how do we recognize these people and triage them effectively to find the right place to put them? So there was a Wells criteria for DVTs to see what your risk factors are for having a blood clot. There's also a Wells criteria for finding if you have a pulmonary embolism. Same thing, signs and symptoms. They give you scores based on what signs and symptoms you have, and based on that you can kind of classify them and channel them appropriately. There's two types. There's a traditional, which is a lot more in-depth, but that has one or two signs that are not specific or not accurate to helping us what it is. Traditionally, if your score is greater than 6, you have a high risk. 2 to 6, you're moderate, and less than 2, you have low risk. What we've done is modified it, and if your score is greater than 4, there's a high probability you're having a pulmonary embolism. 4 or less, PE is unlikely, and you just follow the chest pain pathway. And these are your probabilities for it. If you have 0 to 2, chance of PEs are 3.6. If it's greater than 6, it's 20%. And so these are the risk factors you want to look for, what the causes are. So this is us. Who's here is not from Polk County? By the way, thank you for coming. We appreciate that. We're pretty busy. Our crew's doing an amazing job. But we have basically 3 hospitals that will do this ECOS. And we actually have one out of county, that Osceola, where Dr. Ribeiro works, and I work too, that they actually do it too. So what's our protocol look like? So what we do is we recognize that not everyone's going to have a very fast heart rate, but they're going to have a fast heart rate, and the respiratory rate's going to be elevated as well. And we also ask questions on risk factors. If they have hemoptysis, malignancy, extended travel, immobilization, surgery, all the things that we talked about as risk factors. So there's our first sheet, and we look at all the risk factors that would potentially cause you to have basically indications other than just regular chest pain. Do they have any risk factors that could lead you to think it could be a pulmonary embolism? Page 2, you look at signs and symptoms, but what we did was, if your heart rate was between 100 and 130, or your respiratory rate was greater than 20, then if you only met those specific criteria, you'd be a risk factor for pulmonary embolism. And again, well score greater than 4, we would count you as a positive PE. And this is basically the other form of that, and I'll kind of zoom in on the criteria itself in itself. So what we do is assign specific points. So if you have history of DVT, heart rate greater than 100, previous DVT, hemoptysis, which is coughing up blood, or malignancy. Assign those points. If you're greater than 4, you're a PE alert. So from the pre-hospital setting, what I want you to do is just give oxygen, very low fluids, because if they're in cor pulmonale or right heart failure, the more fluids you give, the worse the outcome's going to be. Remember Starling's law eventually. Remember, the right ventricle is so thin that if you overpower it, you can cause basically death and rupture. We can do pressors. So when the pressure is low, don't give fluids, give pressors. We have dopamine. Other people have different other pressors that you have. At your doses of less than 5, basically your renal doses causes renal artery dilation. If your dose of 5 to 10, it causes increased cardiac effects, beta 1. And if you're at levels of 10 to 20, you're alpha, which causes vasoconstriction. But again, there's many other pressors that anybody can use. That's one we use because we're government and it's cheap. So, Inpatient, obviously, we will take those patients directly to ECOS lab and find out what was going on. In the meantime, they would get anticoagulation, TPA or Activase, inferior vena cava filters, ECOS we'll talk about, and mechanical thrombectomy if that doesn't work. And this is basically your triage pattern of how you deal with these people based on their symptoms, instability, on MAP, and all the above. So greenfield filters, they use this for people with blood clots. They don't use it as much anymore. They put it in the inferior vena cava. So if you throw a clot from your leg, it'll go up and be caught into your, basically in the filter, prevent it going to your lung. And that's what it looks like. Anticoagulation, you got Lovenox, heparin, and Coumadin. They'll start you on Lovenox or Coumadin or heparin first before they wean you onto Coumadin. This is the old days. What they're doing now is Pradaxa, Xarelto, Eliquis, because the lawyers can sue you for more money if you have that. So that's why they have all these other new ones out there. And again, these ones are really good if you have non-valvular issues. They can treat PEs, DVTs, and they don't have to draw your blood every other day to check your INR or every 6 weeks or so. But if you have a stroke and you're on this, you can't give TPA, so they need mechanical thrombectomy. So Activase, which is your TPA, this is your unstable patient. You want to give it to them. If you give it to these people, if they are unstable with a massive pulmonary embolism, especially if your O2 sat's low, MAP is less than 65, these are hemodynamically unstable. They need immediate Activase or some form of clot removal. And mortality is lowered by 50% if you actually give the Activase early. So ECOS, anybody heard of ECOS? It's a catheter goes into the clot. They have ultrasound waves. It breaks up the clot. They give a much lower dose of TPA or Activase, which basically thins the clot, and they're able to suck the clot out. So this is, you see the fibrin that wraps all these clots together. As the ultrasound technique occurs, it kind of thins them. So the receptors that bind the Activase are beneath these fibrin clots. And then once these clots are kind of unwound, the meds can go in there and break up the blood clot that you have. The cool thing is, if you do it quickly, you get much better effects. And they found that basically 48% more drug can get to the receptor with the ECOS in the first hour, and 84% more can get to the clot in 2 hours. So what it does, it gives you much more penetration of this thrombolytics to break up this clot early to decrease pressure in your right ventricle to give you a much better outcome. And there's the ultrasound waves that you have. And this is the breakup before. You see all the clots there, and now after, how you get much better flow. So mechanical thrombectomy, this is left if you are basically resistant to all other therapies. And about 10% of people cannot do Activase, cannot get anything else done, and they're basically a bad patient except for a surgical case. So what they do with these people is they'll basically go in, open up the pulmonary artery and the bronchus and pull the clot out surgically. And 85% do well without any issues or complications, and usually has a really good outcome. Problem is, it involves a lot of stuff, and if you haven't seen one, it's pretty impressive. This is how they pull the clot out. So outpatient treatment, basically you've got your anticoagulants that you take, and basically if they're on heparin, they kind of put you on there, and then after 2 weeks of therapy, they can kind of resolve the embolization that they have. Obviously, Coumadin can be started. You have to keep it INR 2 to 3, but it's kind of a life inconvenient. The big thing I want you to be aware of is, how do you get sued? And we know these two people are more than happy for the people, right? So how do you get sued? So if you have somebody who complains of shortness of breath, anxiety, and you kind of diagnose them clinically as hyperventilation. So especially females, elderly on birth control pills, you're having a panic attack, just relax and you'll be fine. Complaints of unexplained chest pain, and you call it costochondritis, musculoskeletal pain, they will come pay you a visit. And failure to diagnose and treat a DVT and a massive PE for us in the ER is another good way to get sued. So clinically, I want you to break the two down. So scenario one, You've had this patient, Tony Braxton, with all these signs and symptoms. If you look and calculate her well score, it would be, for the sake of time, is 5.5. And so if you calculate that person, just because she's having all these history, she is a positive pulmonary embolism alert. Scenario 2, same lady, what was her well score? She's got cancer, she's got chest pain, shortness of breath, she's tachypnic, heart rate is 22. Her well score is 4.0, so she is a PE alert as well. So clinically, don't tunnel vision. There's your well score again, how you can calculate it. In summary, please build a wall. In that, I want you to be able to try and think and separate pulmonary embolism and just regular chest pain, anxiety, all the above. What are your risk factors you're looking for? Find your risk factors. Do they smoking? Do they have cancer? Have they been immobilized? Have they traveled? Do they take birth control pills? If you don't ask, you won't know. Look at clinical signs and symptoms. Are their heart rate greater than 100, less than 130? Respiratory rate greater than 20? Are they having any other risk factors? Pleuritic chest pain. Are they suddenly massively hypotension, or are they in cardiac arrest? That would be another indication, is it potentially a pulmonary embolism as well. And if you're aware and you keep all these things together, Morgan & Morgan will not come visit you. So, with that, any questions? All right, so we have Dr. Ribeiro here. He's going to do the next one. You ready to come up?